So now we're going to continue our discussion for the core concepts related to the IMM Surgery and allied. So next topic for our discussion is major hemolytic transfusion reaction. Hemolytic transfusion reaction is a potentially life-threatening complication of blood transfusion where the donor red blood cells are destroyed by the recipient's immune system. It is divided into acute and delayed type. So the acute hemolytic transfusion reaction occurs within minutes to 24 hours. It is caused by ABO incompatibility, and the mechanism is IgM antibodies which are preformed in the recipient that activates the complement system, resulting into rapid intravascular hemolysis. Whereas the delayed hemolytic transfusion reaction occurs between 3 to 10 days, it is because of minor antigen mismatch, and the important mechanism is the IgG antibodies, which results into extravascular hemolysis. So further talking about the clinical features which can occur. In acute hemolytic transfusion reaction, the patient can develop fever, flank pain, and most importantly, shock along with dark red urine. These are very important key factors to know. Whereas in delayed hemolytic transfusion reaction, the patient might experience mild fever, fatigue, and jaundice can also be there. And as there is decrease in the hemoglobin after a few days, we can suspect a delayed hemolytic transfusion reaction. So now, how are we going to investigate and what lab findings can be positive? In terms of the investigation, we have the direct Coombs test, which is positive. The plasma hemoglobin will be increased, serum haptoglobin will be decreased, LDH and indirect bilirubin will be increased. So the most important thing is to stop the transfusion and then start the patient supportively, that is, access an IV and start the patient on normal saline infusion to prevent renal failure, because the most likely organ to undergo damage is the kidneys. So our target is to maintain a urine output of more than 1 ml per kg per hour to prevent any kidney damage. However, simultaneously, we have to monitor the vitals, check for the renal function test and the coagulation profile. So how are we going to manage the complications? For the patient having shock, fluid and vasopressors are the treatment guidelines. Whereas if the patient is suspected to develop DIC, then FFPs, platelets and RBCs in 1:1:1 are the treatment options. To prevent renal failure, we have dialysis. And the most important point is to notify the blood bank, because most of these transfusion reactions are caused by the clerical error. So it is very important to notify the blood bank so that the patient's sample and transfusion notes are counter tested so that any further incident in the future can be prevented. So for prevention, we have to have a very strict blood typing and cross-matching, double check patient's ID and unit before transfusion, and use of barcode labels can be optional. So in terms of the board favorite statements for the timing of hemolytic transfusion reaction is that for acute reaction, they will not be giving you minutes to 24 hours, but they will be giving you options like before transfusion ends or within 15 minutes of starting. So these two coins will be highlighting the acute transfusion reaction. Whereas for the delayed reaction, they can give you options like 24 hours after transfusion or less than 4 weeks. So you need to not only have a core concept, but you should also be knowing these facts to conquer the MCQ which are given in the exam. So thank you very much for watching this video.